Welcome to this Pure Voice activity. To access the entire activity, including supporting material, go to www.purevoice.com/cmy. This activity is supported by an educational grant from Bayer AG. Bayer AG has had no involvement in the selection of the speakers, the development of the activity, the agenda, or the materials.
I'm really excited to kick off the CME Educational Symposium entitled Turning Pathophysiologic Promise into Evidence-Based Potential. Is Factor XIa inhibition ready for prime time in secondary stroke prevention? Before we get started, please make sure that your cell phones are in silent or vibrant mode, as this event is being recorded. I'm Ashkan Shwamnesh. I'm a stroke neurologist at McMaster University, and I'm joined by a distinguished panel of stroke experts with me today that really need no introduction, but they include Drs. Jeff Saver from UCLA, Dr. Seeman Chaturvedi from the University of Maryland School of Medicine, who notably is also receiving a prestigious award, the David Sherman Award this week from the AHA, so congratulations. And Dr. Valeria Casso from Saronno Hospital, Italy. We're going to start with a bit of fun in the form of a game show type quiz. Then we're going to discuss relevant aspects of the design and methodology of key phase 3 trials of factor XIa inhibitors in secondary stroke prevention for patients with non-cardioembolic ischemic stroke or high-risk TIA, especially timely since we're all very eager, I imagine, to see the primary results presented by my colleague, Dr. Mike Sharma, who's also in the audience, at tomorrow's main event. Okay, as promised, let's get on with the show. So we're going to try to do something a bit different tonight. We want everyone to participate in this quiz show, in which I will pose a series of questions to both my colleagues and the audience. And if you get your phones and use the QR code to essentially be able to participate, where you'll be able to anonymously log in and actually obtain points based on your correct answers, but also how quickly you create the correct answer. And at the end, we'll be able to share with you the winner within the audience. And if there's a Sharma in there, we will negate that winner and change it to the next person in the list. We will then show questions and answer choices while my colleagues here will have buzzers, and the first to activate the buzzer will get a chance to answer the question. Okay, so just so we're all on the same page and we know that the system works, we'll start with an icebreaker question to warm up and test the system. And again, the answers to select from will be on your phones. So which iconic street in the French Quarter is famous for its nightlife, music, and unique shop? Okay, so we'll wait for the audience and then... All right, well, Valerio's quickest on the trigger. What's the answer, Valeria?
Bourbon Street.
Yeah, well, there we go. And let's see the audience answer, polled answer. Excellent. So the majority of people agree with you.
If I knew it, everybody should.
Excellent. Great. So that will be how this will work. And we'll move on now to the actual main event. Okay, so the very first question is, based on existing real-world data, what is the approximate global recurrence rate of an ischemic stroke at 1 year after a non-cardioembolic ischemic stroke? Your options are A, 1 to 6%, B, 7 to 12%, C, 13 to 18%, or D, 18 to 23%. Oh, okay. Well, I see Jeff has buzzed. Let's wait for the audience, and I'll ask you to answer the question. All right, so Jeff, what's your answer?
What is 13 to 18%, Ken?
No, I'm sorry, Jeff. That is incorrect. Let's see. Valeria, what's your answer?
7 to 12%. Sorry. I have to teach you something.
You're a second. Okay.
I have to teach something to Jeff Saver, so please remember.
And let's see what the audience chose. Oh, 7 to 12%. The audience chose correctly. And we have a slide that provides some of the data supporting this answer. Valeria, did you want to take us through it?
Yes, I think these are very important data about the cumulative 1-year risk. And these are data from Denmark, UK, and Japan. And as you can see, the data from Denmark and UK are almost overlapping 7%. And we have higher incidence from Japan because the patients are also older, but probably there is more intracranial stenosis. And the most important thing about this data is that there are after discharge from the hospital. So not at the moment when we have the highest risk, because we know how many times we had the situation that we have a very immediate recurrence. These are patients who were discharged at home and then have a stroke recurrence.
Excellent. Very good. Okay.
Can I just point out?
Yeah, of course,
that
please.
I thought the pre-discharge recurrent strokes were in the question.
I see.
I think it's say we're both right.
Touche.
Yeah. You know, a man is very difficult to announce something. It's
The points still go to Valeria. No. All right, so the next question is the current standard of care following minor ischemic stroke or high-risk TIA is 21 to 90 days of DAPT based on the point and chance trials. According to landmark analyses of particularly point, what is the suggested optimal duration of DAPT for net clinical benefit? Responses are 1, 21 days, 2, 30 days, 3, 60 days, or 4, 90 days. Oh, Seaman's got the buzzer first. Let's wait for the audience and we'll ask Seaman to provide his response.
I didn't press because I knew everything, so I forgot to press.
It wouldn't be fair if we answered all of them. Okay, let's see the audience. And actually, Seaman, maybe one should tell us your response.
Sure. So,
what is your response?
my response is 21 days.
Yep, and it looks like the audience agrees with you, and that is the correct answer. And we do have a slide to provide the results of basically that landmark analysis that demonstrated this. Could you take us through that?
Sure. Yeah, so as some in the audience know, these trials were designed for 90-day outcomes. And so both the point and the chance study were designed for 90 days for the major events. But then when they looked at the curves to look at the rate of ischemic events after presentation along with major hemorrhage, you can see that the major hemorrhage was sort of persistently climbing up, whereas the ischemic events sort of flattened off after a while. And so it seemed like most of the action in terms of prevention of ischemic events occurred fairly early with the dual antiplatelet therapy. And so therefore, when you combine those two aspects of the potential risk-benefit ratio, then the optimal time appeared to be 21 days. And so that's been ingrained in many practices these days.
And just out of mere curiosity, because guidelines still allow the original criteria for the studies as well as part of the duration of treatment, what is the length that you use in your own individual practices? Maybe Jeff, you let me know.
I do use 21 days in most patients with minor stroke or TIA. The exception are the patients with intracranial atherosclerosis based on Sampras, where we'll do double antiplatelet therapy. Not that that's been proven better, but it's the established medical reference better than intervention. So, and there's theoretical reason to think that there'd be greater thrombosis proneness for the intracranial athero patients.
Excellent. Yeah, anyone
Also for
differently?
symptomatic chronic stenosis, if I'm not going to intervene, if they have, say, 50, 60, 70% stenosis, those patients I also sort of extrapolate from Sampras and treat for 90 days.
Valeria, any other thoughts?
No, I can only add, I follow the same scheme.
Yeah.
Yes.
And likewise.
Yes.
Great. All right, get ready for the next question.
I'm going to steal yours.
Which of the following correctly describes the association between genetic disposition to factor 11 levels and risk of ischemic stroke or myocardial infarction? The responses are higher levels is associated with decreased risk of ischemic stroke and MI. Lower levels are associated with a decreased risk of ischemic stroke and MI. Higher levels are associated with I can't actually see that, so use. Who's in the audience can see what actually is.
Hit it. Oh, he didn't read all the.
Well, the audience, you'll get them on the phone. But I know our expert responses, including CMANT, will know this, irrespective of not being able to see the answers, potential answers. So, CMANT, what do you think?
No, that's how clairvoyant I am. I can know the answer without even seeing the options. No, so I think that the correct answer should be a decreased risk of stroke, but no effect on MI.
Yeah.
Excellent. That is indeed the correct answer. And let's see if the audience was correct on that as well. Amazing. Very good. Well done, audience. All right. Next, and here is basically, did you want to take us through this, Seaman?
Yes. So there have been a variety of studies to look at this issue. And one has been like a Mendelian randomization study where they looked at the effect of various endpoints, and they found a decreased risk of venous thromboembolism as well as ischemic stroke in the patients who had lower levels of factor 11. And so, whereas they found a neutral result with regard to MI. So that would sort of explain the correct answer.
Wonderful. All right. In the COMPASS trial, what was the approximate yearly relative reduction in ischemic uncertain strokes in the rivaroxaban plus aspirin group versus aspirin alone? Options being 5%, 15%, 30%, or a 50% relative risk reduction. Well, Jeff, let's see if you can redeem yourself from that first question.
I'm always here.
Okay, go ahead, Jeff.
What is 50%, Ken?
Very good. That is indeed the correct answer. And the audience? Ooh, wider spread here. So that's great. We can actually teach you something today. Do you want to do that, Jeff? The next slide?
Sure. So here are the findings from COMPASS, and on the left you see the Kaplan-Meier curve for recurrent ischemic stroke or unknown stroke type, with the rate in the combined group, the dark blue at the bottom, being much lower than in the aspirin alone group and lower throughout most of the course than the rivaroxaban group, and it is a nearly halving of the events. On the other side, you can see the bleeding rates, and there was an increase in major bleeding with the combined therapy, but no increase in intracranial bleeding or in fatal bleeding between the combined therapy and the aspirin groups. I think the audience's selection of 15% rather than 50% reflects the lack of uptake of this treatment and also to be in COMPASS, you couldn't have stroke as your qualifying event. You had a cardiac or periphery, so it doesn't directly apply to us, but I don't think people intuit that it's such a strong result in COMPASS. And I'm also going to make one other point. I've had to change my thinking about the cause of stroke based on the COMPASS results. I've subscribed to the classic Kaplan notion of red clots and white clots, and that white clots form in flow streams of rapidly flowing blood over athero and platelet activation, so antiplatelet drugs are best for athero, whereas red clots form in stasis in the veins or in the non-beating atrium, so anticoagulants best for that. But it turns out there's a third major mechanism, and that's release of tissue factor when the endothelium is injured. And tissue factor is a potent stimulus of the coagulation system. So I think that's the pathophysiologic response that we have to update our classical learnings and recognize that anticoagulants are a good option, but you have to put up with the potential bleeding risk with some anticoagulants, but a good option along with antiplatelet therapy for atherosclerotic disease.
Yeah, excellent. Any other thoughts on the panel?
Yeah, one other point I'd make is that our colleagues in hypertension have taught us that sometimes if you use multiple drugs from different classes with submaximal doses, then that can be very effective. And so this is giving us something a little bit analogous, where a submaximal dose of rivaroxaban combined with aspirin turned out to be efficacious.
Yeah, I think especially in high-risk patients, what you always teach us, and Mike also, the dual pathway in order when you have atherosclerosis, and probably what you said, the white and the red clot, probably is something in between, because we have to push probably a little bit harder to protect the vessel. It's the endothelium, because atherosclerosis is the endothelium, and probably antiplatelets are not enough. We need something else, maybe a kind of anti-inflammatory action that we still do not know from the small doses of anticoagulation.
Yeah, for certain. And I think where this strategy also is quite attractive is in patients with ESUS, right? Because you have a heterogeneous population of patients with different sources of thrombi that you haven't identified. Having a broader coverage with dual pathway inhibition could also be very attractive in that regard. And there was some suggestive data from COMPASS to indicate that those patients, that at least as far as outcome events that were reduced, ESUS were reduced the most.
Yeah.
Very good. Last question. This is actually going to be an open question because we are very privileged to have Dr. Casso on our panel, who was co-principal investigator of the OCEANIC-AF trial. As many of you know, unfortunately, OCEANIC-AF was stopped prematurely due to the lack of efficacy of asundexian versus an active, very effective comparator, and that is apixaban. But now on the heels of knowing the top-line results of OCEANIC-Stroke, that these were positive, that there was a reduction in the primary efficacy endpoint of the trial, which was time to first occurrence of ischemic stroke, without, importantly, any excess in the primary safety endpoint, that was time to first occurrence of ISDH major bleeding. What do you think accounts for these differences that we're seeing between OCEANIC-AF and the OCEANIC-Stroke trial?
So first of all, OCEANIC-Stroke, there's on top of antiplatelets, dual and single. Second, atrial fibrillation, we still have to prove is if factor 11 really works, because still we do not have, at the beginning we thought maybe it's the dose, it's the molecule, but still there are some studies ongoing trying to show if factor 11 is really the right drug for AFib patients. Because again, I think it's again about the thrombus. You say this is a fresh thrombus coming or embolus coming from the heart. Do we really know if factor 11 in this case is the right answer to this condition in this type of patient? So it's something that we need to understand, and there are other trials going on, and hopefully, as we always hope, that there is a new drug and a new possibility for the patient, but still we have to understand if the pathomechanism of the stroke is also the answer for this.
Yeah, excellent. Yeah, and I agree. So there's really two glaring kind of potential answers here. One is, of course, completely different disease population. One was in patients with atrial fibrillation, cardioembolic stroke. Here we're looking at patients with non-cardioembolic stroke, so different substrate. The other is the comparator, right? You guys, apixaban, we know, is a very effective preventer of stroke in patients with atrial fibrillation. And so that was the comparator for OCEANIC-AF. For OCEANIC-Stroke, the comparator is placebo, and we're using it on top of standard of care. So those are, off the bat, two potential explanations without getting further into the weeds. So I think that for anyone here, there's the negative results of OCEANIC-AF raise any eyebrows for you or reduce your enthusiasm of learning the positive results of OCEANIC-Stroke based on these differences?
Well, I would have loved it to work for both conditions.
A lot of people in this room.
Both of my tremendous enthusiasm for something that treats every cause of stroke, but I'm very happy to settle for something that is beneficial for non-cardioembolic stroke, in part because there are the very clear reasons to understand the divergence results that you've outlined.
Yeah, excellent. Very good. So before we get into our next segment, which is from trial protocols to enroll populations, how we put the factor 11A hypothesis to the test, can we see the winners of the polls, of the Q&A? Oh.
Wow.
Croc. Well done, Croc. Oh, hey, Jason, get up, take a bow.
Let me see, if we gave extra points to Bodie McBoatface for the great name, I'd call it a tie.
Yeah, fair. Extra points for the great name. All right, great. So maybe I'll ask Cement, could you please take us through the design of the LIBREXIA-Stroke trial?
Sure. Yeah, so the LIBREXIA-Stroke trial is looking at milvexian versus placebo, and this is a large study, as indicated, with over 800 sites. And it's looking at the population of non-cardioembolic stroke or high-risk TIA within 48 hours of stroke onset. And it's a large study with projected about 15,000 participants. And as the question alluded to, there are some differences in terms of the NIH stroke scale criteria between LIBREXIA and OCEANIC. And LIBREXIA is looking at a milder population with an NIH score of 7 or less. And it is including very high-risk TIA patients, as indicated on the slide with the ABCD score. And subsequently, the patients will be randomized to milvexian 25 milligrams twice a day on top of background antiplatelet therapy. As Dr. Casso said earlier, this could be on top of either single or dual antiplatelet therapy, and this will be compared against placebo. And then subsequently, patients will be followed for up to 41 months, and major bleeding is going to be the primary safety endpoint, with the most serious bleeds being intracerebral hemorrhage or intraocular or any fatal bleed. In terms of the inclusion and exclusion criteria, you can see the key criteria listed here. The time window for enrollment is different from OCEANIC, where they're looking at patients within 48 hours of symptom onset, and they have to have objective evidence of cerebral ischemia in terms of either the clinical exam or the imaging, and then the antiplatelet therapy is according to standard local practice. Some of the key exclusions which you would expect in a antithrombotic trial include prior intracranial hemorrhage. Also, the patients with cardioembolic stroke are not intended for this trial, so patients with AFib or valvular disease are excluded. Also, patients with other causes such as dissection are excluded, and those with significant recent bleeding or those with active liver disease.
Yeah, great. And Valeria, would you mind taking us through OCEANIC-Stroke?
Yes, thank you. Probably you know, because I saw many of the investigators also in the room. So this is OCEANIC started in January 2023 until February 2025, more than 12,000 participants. And again, patients over 18, non-cardioembolic stroke or high-risk TIA on standard antiplatelet therapy, which could be single or DAPT. Importantly, the ischemic endpoint, the primary endpoint was ischemic stroke or ISTH major bleeding. The secondary endpoint, I will not go through it, you can read it. And those patients were randomized to asundexian 50 milligram once daily on top of antiplatelet single or DAPT, compared to placebo antiplatelet single or DAPT. The most important inclusion and exclusion criteria are patient aged over 18 within 72 hours of symptom onset. And you can see, interestingly, a patient with an NIH 215 could be included. This means that you could include patients who perform thrombectomy, so severe patients. High-risk TIA with an ABC2 score of 6 or 7. In presence, when you have lacunar stroke, there must have been a history of atherosclerosis or non-lacunar stroke, and the plan for antiplatelet single or dual. Clearly, the key exclusion criteria are almost similar to the LIBREXIA trial, so there clearly a history of AF was excluded. Ischemic event could not be 1 week before randomization, so it was not a very early recurrence. And it could not be patient with a perioperative stroke, which has a different mechanism. Patient with end-stage renal disease could not be included, and clearly no active bleeding, no history of active bleeding, no history of intracerebral hemorrhage, non-traumatic intracerebral hemorrhage were permitted.
Excellent. Thanks for that great overview. And then we're actually thrilled of how well OCEANIC-Stroke was performed across our network around the globe. This was a valiant effort at over 700 sites in 37 countries. And actually, the baseline demographics I'm going to show to you today were recently published this week in the European Stroke Journal, where you could also find the rest of the methods of the design of the trial. So please refer to them after the symposium. But in total, 12,327 participants were enrolled in just over 2 years. We started enrollment in December of 2022 and finished enrollment in February of 2025. This was a large global representative sample of the target population of patients with non-cardioembolic ischemic stroke or high-risk TIA. The mean age was roughly 68 years old. We had significant efforts to improve the representation of women in our study, but unfortunately, consistent with most stroke prevention trials, there was still underrepresentation, but a third of the population was female. 20% had a prior history of stroke or TIA other than the qualifying event. 16% had history of coronary artery disease. Hypertension was prevalent in 80%, diabetes in 34%, and 27% of the population were smoking at the time of enrollment. The majority of events at onset that led patients into the study were ischemic stroke. 95% were ischemic stroke, and 5% were TIA. And this really reflects the high CHADS-VAS score the ABCD2 score that was required to get into the study. It had to be either 6 or 7, which is a smaller but very much higher risk subgroup of patients with TIA. Next, we're showing you the distribution of ischemic stroke subtypes. And what's important here is seeing the large distribution of different non-cardioembolic ischemic strokes that got into the study. 5,000 patients with large artery atherosclerosis, 43%. As far as I'm aware, if this was going to be a standalone trial, this would be the largest trial ever conducted in large artery atherosclerosis as a subgroup. Next, strokes of undetermined etiology, 3,500 patients, or 30%. The second largest embolic stroke of undetermined stroke or source trial, ESIS study, was RESPECT-ESIS that had 5,000 participants. The third largest, Arcadia, had 1,000 participants. Small vessel occlusive disease, 2,600 patients roughly, 22%. The largest lacunar stroke trial ever completed was the SBS3 trial, 3,000 participants. So you can imagine with a trial of this magnitude, even these subgroups are going to be informative just due to the sheer number of participants. And I'm excited to say that after the main plenary, we will be providing the key secondary analyses by qualifying ischemic stroke subtypes in the afternoon tomorrow. NIHSS at presentation was 3, and the median was 3 as well, so actually normally distributed. I'm going to show you the mean and the median, but just the median. And the max was up to 39, and the interquartile range was 2 to 6. At randomization, after patients had the option of either getting thrombolysis, EVT, or having some time to improve up to 72 hours, the NIHSS had reduced a little bit to 2 with a max of 26, an interquartile range of 1 to 4. What's interesting is that although we often may think that this is maybe lower than what we would expect in patients with non-cardioembolic ischemic stroke, we actually performed a dive into the literature of observational hospital-based registries where there's no selection bias also looked at randomized trials of patients with non-cardiovascular ischemic stroke where there wasn't an antithrombotic being introduced and a drug like colchicine was being used, like in the CONVINCE study, where there shouldn't be concerns about higher stroke volumes and bleeding risk. And actually, this is quite representative of what we would expect in this population. Next, we wanted to ensure that we had adequate representation of patients that we see on a day-to-day basis who end up getting acute treatments. 27% of the population received either intravenous thrombolysis or endovascular thrombectomy. 20% received thrombolysis, which I would say is quite impressive and kind of competes with some of the highest rates or the best countries in terms of proportion of acute ischemic strokes that receive thrombolysis. Endovascular thrombectomy was in 3% of participants, and about 4% received both. And then lastly, our randomization was stratified according to planned antiplatelet therapy. Dual antiplatelet therapy was planned in the majority of patients, 2/3 of the population, and single antiplatelet therapy in 1/3. So really, what's great is that stroke is a global disease, and we will have a global answer tomorrow after the main plenary presentation. What we know from the global burden of disease study is that stroke is not only a major burden of death and disability around the world, but it's also increasing with our aging demographics and changing in demographics in this global south. At present, we estimate that each year there's 5.5 million patients with non-cardioembolic ischemic stroke who could benefit from this treatment. And we're really excited for this new paradigm shift in stroke prevention on the heels of the OCEANIC-Stroke trial. So as we've expressed today, and I thank the panel for really their expert insights and discussion, as well as the participation from the audience. And we're about to get into a Q&A, which is where LIBREXIA left the most time for that because we want to be able to answer as many questions as we can. But what we've established thus far is that there's a large unmet need in secondary stroke prevention. Factor XIa inhibitors are investigational agents for the prevention of recurrent stroke. However, inhibition of factor XIa represents a promising target due to its potential, which is essentially now established, to uncouple hemostasis from pathologic thrombus formation. The OCEANIC-Stroke and LIBREXIA-Stroke phase 3 trials are basically going to be answering this question, and we'll get the answers tomorrow in the details for patients with non-cardioembolic ischemic stroke or high-risk TIA, and really looking forward to celebrating the results and the details of the results with you tomorrow.
Let me just say, I think this was mentioned, but I hope everyone knows OCEANIC-Stroke is a positive trial.
Yeah, it was mentioned. It was mentioned.
It was mentioned.
Yeah.
So Ashkan is being very conservative. He fell back into saying, well, but this is a win. This is a transformative moment. And so the full details will be coming, but the press release was issued, so that is no longer under embargo. So we can openly talk about that this is a positive trial.
And just to reiterate, not only is it a positive trial on the basis of meeting its efficacy endpoint for ischemic stroke, but what's really important here, and it's paradigm changing, you could say it's revolutionary really, and historic, is the first time we have an antithrombotic that's preventing thrombotic events without increasing major bleeding. And we'll also see some of the results in terms of safety for other bleeding outcomes tomorrow, which are equally impressive.
Just to add something, think about, I'm now in this field 30 years. So to see positive trials is extremely rare, especially for us as neurologists. And we clearly, as you said, Ashkan is very conservative, but I was there when Peter Sandercock presented the IST trial about aspirin. It was the first time that we heard about secondary prevention after a stroke. And now we are here, think about all the steps that we made. And we are here now for everybody is very excited for tomorrow, but there's something really changing. And we did a good job over the years, but there was a missing piece. And I think this is for us and all the investigators that are here, I think this is something that we really have to celebrate. Take us 5 minutes really to celebrate this.
Thanks. Seema.
Yeah, Ashkan, I wanted to make a couple of points. That as somebody who's been heavily involved with trials looking at large vessel atherosclerosis, such as WASID, SAMPRAS, CREST, CREST-2, I think your point that this is the largest standalone trial of antithrombotic therapy for large vessel atherosclerosis is really remarkable, with over 5,000 patients. And so I think the fireside chat where you take a deeper dive into the data according to the stroke subtype will be very informative. And then also I was sort of very impressed with the fact that how the dual antiplatelet therapy has been adopted and strongly embraced by the community, where you can see that over 60% of the patients were on dual antiplatelet therapy. I think that's sort of a testament to the ability of the previous clinical trials to shape practice.
Yeah. Excellent points.
And speaking of the dual antiplatelet therapy, I want to be the first to propose an acronym for what's coming, because it's not just going to be DAPT. We're going to be using 3 agents, but one is not antiplatelet, so the PS is dropped. So I'm going to propose TAT, triple antithrombotic therapy. So that will be what we'll be doing beginning tomorrow.
So also to distinguish us from the cardiologist. No, to say we're doing something very special. And think about also the representation of the patient population. It's all over the world. So, you know, when we started trials, it was for only high-income countries, small population. Now we have, as you said, we have atherosclerotic stroke, intracranial stenosis, which is representative for Asian population. We have severe, we have lacunar stroke, but you know, it's always the fear that you get too many lacunar strokes in order to dilute the results. Here there was a good selection because we had lacunar stroke together with atherosclerosis disease. So we will have a wide representation of the stroke population, not only European, not only Western, but also Asian and other population. I think this is absolutely 12,000 patients all over the world is really
And to your point, I think the forest plots tomorrow, when Mike presents the results, primary results, and looking at all the different subgroups, depending on race, geographic region, age, sex, will be very important interpretation of results, and seeing how broadly applicable this will be for our patients that we see on a day-to-day basis in hospitals. So look out for those as well.
And especially, and you showed this map before, never forget that 80% of strokes are occurring in low and middle income countries with a high burden of disease. We don't know why there's a higher burden of this atherosclerotic disease. So we have to offer something more. And we started, every trial that we do needs to be generalized. We need to be generalized and affordable. So it's now our job to bring the drug to where it's really needed.
So on that, we will now move on to our Q&A, where you basically have the option to ask us anything. It could be on topic, off topic, but really this is your chance to ask the experts your burning questions about management, and in particular about factor XI inhibition and how this will affect your practice. So the first question that I see here that I'll ask the panel, and there are 2 that are similar, but essentially it speaks to the mechanism of factor XIa inhibition. And how does it uncouple thrombosis or pathologic thrombosis from hemostasis? I know, Valerio, you've given this a lot of thought, well, the whole panel has, but did you want to get us started?
Yes, so for me, the coagulation cascade was always a big mystery. So being factor XI part of the whole cascade, you block this mechanism only for the thrombogenesis without blocking the hemostasis. So it's something that I wish John Eichelbaum would be here, because he would be much better than me to explain it. But however, blocking factor XI, you block only the hemostatic, the thrombotic, you don't block the hemostatic effect.
Yeah. And what's quite neat compared to factor 10 inhibitors is that, so factor 10 inhibitors, they're really in the direct kind of the common pathway, right, where the intrinsic and intrinsic pathways meet, or if the contact pathway or tissue factor pathway meet. So that's a downstream effect that blocks thrombosis, but also has an effect on hemostasis, right? It's not as bad as a shotgun like a vitamin K antagonist where you're knocking out all vitamin K antagonists or relevant factors like 2, 7, 9, and 10. You're just either getting 10 in isolation or 2 in isolation. So less bleeding than a shotgun, but still downstream. What's really interesting about factor 11 is that it's strategically placed in a thrombin amplification loop that is very relevant for clot propagation, right? So if you have a plaque rupture, for instance, from atherosclerotic plaque, you need factor 11 to basically for a small clot to become a big clot that either occludes a vessel or becomes a large mobile vessel, a mobile thrombus that could then embolize distally to the brain. Whereas when it comes to the hemostasis after vessel injury, there's so much tissue factor that lives in the vessel wall that gets exposed to the circulation that in of itself is enough to cause hemostasis. And factor 11 has really a minor subsidiary role in that setting. So thereby, by blocking factor 11, you maintain the hemostasis. You're only blocking that thrombin propagation loop that leads to pathologic thrombus formation. So you knock out the pathology, you maintain normal hemostasis. And that's been the hypothesis that we think we've now actually proven through the OCEANIC-Stroke trial for the first time.
And some similar observations have been made in the patients with genetically low levels of factor 11, that they tend to have very relatively little in terms of spontaneous bleeding as opposed to, say, hemophilia.
Exactly.
Yeah.
And I'm going to ask a question that I hadn't thought about before. In the genetic Mendelian studies, why do we think that you prevent stroke but not MI? I have a hypothesis based on what you just said, so you go for it.
Okay. So it's pure speculation, okay? And on the surface, it doesn't make sense, right? It is in patients with factor 11 deficiency, you have no MI. The rates of MI are similar to the general population. Rates of stroke and venous thromboembolism are reduced. Why is that? And you can't say that it's because of PCIs or antiplatelet therapy, because these are not trial participants who've already had an MI. These are just people who are factor 11 deficient walking around. So one hypothesis I've had when I first saw this is the only way I could explain it, is vessel diameter and lumen diameter.
Yeah.
In that, if you have a relatively small vessel like a coronary, and then you add the pathology that leads to MI, which is atherosclerotic plaque, so now you have a small vessel that is already the lumen is narrowed even further by that plaque, that initial clot that gets formed without the factor 11 propagation loop would be sufficient to block that vessel and cause an MI or pathology. When it comes to larger vessels like veins, or larger vessels like the vessels that lead to the brain, and even kind of intracranial vessels that don't have the same degree of stenosis, where the lumen is larger, that initial thrombus will not be sufficient, and you need that propagation cascade to lead to pathology. That's a hypothesis. We can talk about some of the subgroup findings tomorrow in terms of stroke subtype and how that challenges perhaps that hypothesis or not. But that's the best I can do. How about you, Judge?
Well, that's what I was going to suggest. So I'm glad to know that you beat me to it by a long time period.
But I think this was also the reason why you excluded poor lacunar stroke. So without atherosclerosis, I think this is, for me, all what is in the white matter, small vessel disease, it will not work as much as in large vessel disease.
Yeah. And that was a suggestion we saw from phase 2.
Yeah.
is an interesting story because once we see the final results tomorrow, it'd be great to have another discussion about how we could sometimes be misled by phase 2, or dig a little bit deeper into what's different about the lacunar strokes that got into oceanic stroke versus the larger lacunar stroke population. Yeah, for sure. Excellent. All right. Next question is, how do the differences in patient population from OCEANIC versus LIBREXIA compared to real-world patient populations in terms of NIH score and time? And do you think these will have any bearing on clinical practice if both trials were positive? Maybe CMAT, you want to take that?
Yeah, no, as I think you sort of indicated that once you remove the cardioembolic strokes and you look at the patients with non-cardioembolic stroke who are relatively stable in the first 2 to 3 days, you are going to have a majority of patients who have NIH score of 5 or less. And so I think that was demonstrated in the trial with the oceanic patients having an NIH score of 2 for the median score at the time of randomization. And assuming the LIBREXIA-Stroke trial comes in with a fairly similar NIH stroke scale, then I think the populations will be somewhat comparable from that standpoint. LIBREXIA-Stroke doesn't have the requirement for evidence of atherosclerosis, and so that will be one difference, and we'll have to see, according to their subtypes, how that matches up with what was enrolled in Oceanic. But I have a little doubt that this is going to be applicable to a large number of patients that we see in actual clinical practice once we remove the non-cardioembolic stroke patients.
Consider that when you include patient with you plan to include patient with an NIH of 15, it means that you are very confident about the safety, because you include patient who perform thrombectomy. So it means large vessel disease, the worst type of stroke that we can have. So on this side, we are very safe. There will be additional data from LIBREXIA, more selected, but in the end, you have already such a difficult population included in Oceanic. I don't think that there will be, this will not affect, because you have already everybody included in Oceanic. You will have some other data which will support, hopefully, what we already found with Oceanic, but you already have these very severe patients inside the trial.
And I would add, if you look at unselected consecutive stroke series, including cardioembolic and non-cardioembolic stroke together, the dirty little secret is that the median NIH stroke scale is 4 to 5. We don't want people to know that, because everyone says stroke's a terrible disease. It gives major deficits, and we want them to think that when they're funding us. But most strokes are minor. And then when you take the cardioembolic strokes out, which are more severe, it's very understandable that you end up with a 3. But it is also important that Oceanic went up to 15. So this is really extending the range of presenting severity that can be treated. There was a trial from China that looked at double antiplatelet therapy up to nearly 15, I think.
7 spires.
And also showed benefit. So I think we're learning that also, if you look at Elan and the anticoagulation early trials, that in the modern era of good blood pressure control, the risk of hemorrhagic transformation after the first few days is not as great as it used to be. Plus, if you're a drug that's not causing hemorrhages, you don't have to worry about that. But even for double antiplatelet therapy, a lot of these patients, presumably, we'll see what the breakdown was for single versus double once you get above 5. But probably a lot of them got double just still.
Yeah, very good. Like Valeria, then you didn't use your buzzers, guys, right? See your finger go up sooner, Valeria.
Now, just to come back to the 7 to 12%, sorry. But think about if an oncologist say to a patient, you have a risk at 1 year to have recurrence of 7 to 12%. Okay, this is what we have now, and this is what we have to move from. So this is something we never realize what it means for a patient to say, now you have 7 to 12% risk of recurrence. Again, to go through this hospitalization, again, to find yourself in a stroke unit, to have another stroke, to learn again to speak, to learn again to move, to walk. And this is absolutely, for me as a neurologist, not acceptable that I have to share this data with my patient. So to have an additional chance to reduce this number, to say at least we can discuss about the next 5 years, not 1 year, this will absolutely change the behavior and also the prognosis of my patient.
Excellent. Steven?
Yeah, the point I was going to make is that we also have to keep in mind that patients who underwent thrombectomy were eligible for OCEANIC. And some of those, as all the clinicians in the room will know, sometimes as our interventionalists have gotten more and more skilled and the rate of TICI-3 recanalization has improved, sometimes they have dramatic improvement and they go from NIH score of 15 to 2 or 20 to 3 within the first 48 hours. And so those patients could easily have fit within the OCEANIC criteria.
That's actually an insight we have now that we didn't really have from the point and chance trials, right? Because thrombolysis was an exclusion for those studies. You had to get them in within 24 hours. Inspires went up to 72. But we also we always had to kind of use our own clinical judgment as to whether we go based on their presenting NIHSS or their post-thrombolysis NIHSS to whether to give them TAPT or not. Here we don't have that issue because indeed a large proportion of patients were actually received thrombolysis before getting into the study.
And it illustrates that the presenting deficit in acute stroke reflects the perfusion lesion much more than the core lesion. There's a large area of brain that is dysfunctional and causing deficit, but not irreversibly compromised. So what's important for bleeding risk is the irreversibly compromised tissue. And once you do thrombectomy and remove the perfusion dysfunctional tissue and you're left with a small core, that's what you have to worry about.
And would you have thought that 1 year or 2 years ago that you would give aspirin plus an anticoagulation after thrombectomy? So this is something we are, at the beginning we were like, okay, aspirin after thrombolysis, we wait 24 hours. Now we are, without thinking, we gave antiplatelets plus anticoagulant after 24 hours after a procedure. So I think this is absolutely changing our view of the brain tissue and how we can treat this ischemic issue, damage.
100%. Yeah. Very good. Ooh, next question. LIBREXIA-Stroke is still enrolling. What do you think about the fate of LIBREXIA? Maybe I'll answer this. So I would say, one, of course, OCEANIC-Stroke we know is positive. We don't have the details yet. We'll see those tomorrow. But the drug's not available, right? If I was an investigator, I'd be even more motivated to get my patient into that trial so that they could have access to a drug that's at least a similar drug has already shown benefit, right? So I think I wouldn't be surprised if actually, based on the positive results of OCEANIC-Stroke, enrollment picks up in LIBREXIA-Stroke.
Yeah.
Secondly, I think the more patients we have across both these trials, the better, more confidence we have about this mechanism. There are nuances in the compounds. If one ends up being negative, one ends up being positive, there's still good reasons as to why might that occur. But the best possible outcome is that both these trials are successful, right? That would give us the best confidence for our patients. It would increase the uptake of this new class of medications, I think, more rapidly. So if you are participating in LIBREXIA-Stroke onwards and upwards, I encourage you to enroll even faster now with the option of providing a treatment that would not otherwise be available to your patients that may be as effective as what we're seeing in OCEANIC-Stroke. And when you look at some meta-analyses of Pacific Stroke and axiomatic SSP, and even looking at some of the data from OCEANIC-Stroke, the overall treatment effects look fairly consistent across the board. So I actually anticipate LIBREXIA-Stroke to be positive as well.
Mm. No, I totally agree with you. So the question should have been, if an Oceanic was negative, should they continue? So, but now I think the positive trial is only to, as you said, it's not licensed. We need more data. So absolutely and every trial is an occasion for the patient. So this randomization has to continue.
And Ashkan, let me ask you, speaking about when this drug is going to be in people's hands, speculating what FDA will do is always challenging. In these particular years, it's particularly challenging, but what's your guesstimate about how long to get through FDA approval and onto market?
My guesstimate is hopefully for the FDA, it'll be fourth quarter of this year, or first quarter of 2027. But the sooner the better for our patients. I have to say that because I was just on the stroke unit earlier this month, at least in January, and many questions, I'm sure you all have this experience as well, will ask you, well, what's my risk of recurrence of this happening again, doctor? And I said, well, you've had a non-cardiovascular ischemic stroke. In her case, it was ESUS. So risk of recurrence is going to be somewhere between 6 to 7%. And then she's like, oh, she got a bit down. I'm like, well, odds are 93% per year, you're not going to have a stroke. So think of it the positive way. And what's even more positive is that we've actually just proven that there's a new drug going to be coming out, hopefully within the next year or two, that's going to be able to reduce that risk for you for another 25%. And just that sentence, you could see the patient's face light up and actually regain hope and see that there's still light at the end of the tunnel. And I think as scientists, we get really excited about the data. We focus our daily day on implementing these trials, but really what really matters is the benefit we can provide patients through the conduct of these studies, particularly when they're successful, as OCEANIC-Stroke is. Yeah. Okay, so the next question, Jeff, you kind of mentioned about your use of Compass and why you use it in your practice and the large effect sizes that we're seeing when factor 11 inhibitors are on the market. Is there any scenario where you would use the Compass regimen in lieu of factor 11 inhibitor?
I suppose if somebody had factor 11 allergy, yeah.
Yeah.
But, we have to see the exact data and look at subgroups to see if there might be any subgroup that differentially did better. But, since Compass is not in stroke patients and Oceanic is, again, unless they can't take factor 11, I think I'm going to be going with factor 11.
Particularly in a stroke patient, right? Yeah. So in a stroke patient who otherwise would have met Oceanic-Stroke criteria, there's no reason to favor the Compass regimen. And the main reason to favor this is that you don't have the bleeding risk that's associated with it, right? The patients where you should still consider the Compass regimen, of course, are those that have peripheral arterial disease, kind of multivessel coronary artery disease in the absence of a recent stroke. Yeah, excellent.
And earlier Valeria was mentioning the Oceanic AF results. And even though the Oceanic AF top-line results were negative, sort of a forgotten observation is that there was actually less bleeding in the asundexian group compared to the apixaban group. And so if you have a patient who is very bleeding prone, like a lot of white matter disease on their MRI, or elderly or previous GI bleed, I think that's a patient who could do very well with asundexia.
Yeah, 100%. And I think that point cannot be overstated, right? Because we've had experiences where apixaban has gone up against aspirin in a similar population, right? Such as in the Averroes study. And there, the bleeding events of apixaban were similar to aspirin. In the Arcadia study in patients with ESUS, bleeding events of apixaban were similar to aspirin. Interestingly, when you look at hemorrhagic stroke, there's actually numerically less bleeding in the brain with apixaban versus aspirin. in OCEANIC-AF, Valeria and the cardiology team at Duke showed that the rates of bleeding with asundexian versus apixaban are half.
Yeah.
Bleeding rates in the brain were 70% less, right? Indirect comparisons are prone to faults, but this would suggest that this drug is safer than aspirin, right? And we'll see some other suggestive data in that regard tomorrow from Mike.
Which brings up the question, if you have a patient who's had an intracerebral hemorrhage or has 50 microbleeds, but has had an ischemic stroke, and you, with athro, and you want to treat, but you'd hesitate to do antiplatelet therapy, can we think about giving this agent alone as monotherapy? And we're going to need to collect data about it, but it's going to be an issue that very uncommonly comes up.
Yeah, for sure. And there was this 30% of patients that got into OCEANIC-Stroke where the intention was to use monotherapy, and then seeing how patients did tomorrow in the forest plots, whether they were intended to adapt versus monotherapy, may provide further insights on that as well. Yeah, very good. All right, next question is, and this is an important one, especially as we're going to be increasing the use, because non-cardiometabolic ischemic stroke is going to be about 70% of ischemic stroke subtype, of all ischemic stroke, right? So these patients, based on the data we're going to see tomorrow, are going to benefit and should be started on factor 11A inhibitor. But there's going to be some uncertainties that are going to arise in practice as a result. And the next question actually addresses one of those, and is, should patients who are on a factor 11A inhibitor be viewed as a contraindication to thrombolytics? Who wants to take that one on?
That's up Jeff Sally.
Well, I would not at the moment expect that to be a major contraindication to thrombolytics. We now recognize that DAPT is not a contraindication of thrombolytics, and if there's no increased bleeding risk from this agent on top of DAPT, then I would think it would be safe to do. But there should be some data coming out of OCEANIC of patients who had a stroke event while on active therapy and to get thrombolytics, and I think that's really going to guide us.
Yeah, 100%.
We have also indirect data from factor 10 that we can thrombolyze this patient without dosing and safely thrombolyze these patients.
So the answer is, really, we don't know, right? But I think we can make individualized decisions on a case-by-case basis. And on the fact that we have great observational data to date, demonstrating that you can thrombolyze patients on factor 10A inhibitors, at least suggesting of that. And now there's ongoing randomized trials that have been developed on the basis of the observational data that could happen. And we are doing it on a case-by-case basis. And that's a drug that has higher potency towards bleeding than factor 11 inhibitors. I think it would be very reasonable to take a similar approach with factor 11 inhibitors. It's worth noting that there is animal data that shows that if you treat an animal with factor 11A inhibitor and thrombolyze it, it has the same bleeding potential as a factor 11A naive animal that doesn't have any antithrombotics on board that has thrombolysis. So there is some proof of concept there in animal studies. And that in the OCEANIC-Stroke trial, we essentially allowed thrombolysis if patients had a stroke during study participation. We left it to the discretion of the investigator. Again, a case-by-case decision-making. But what we have done is collect the images of those patients so that we can look at the rates of hemorrhagic transformation in those that receive thrombolysis while on a factor 11A inhibitor. And there is going to be an abstract presented at ESOC where we also are able to look at their outcomes as far as MRS and NIH stroke scales if they got thrombolysis or not. So we are going to have some data to help you in this regard. Now, we already have reassurance from Pacific Stroke as well that patients who got into that study who got thrombolysis prior to randomization, they had no excess bleeding, right? That's a bit of a different scenario because they got their thrombolysis They then got their drug 24 hours after, but that's some early reassurance, but we're going to have any additional, hopefully, reassurance from these other studies I mentioned that are going to be forthcoming.
And an additional aspect is often the patients who have an ischemic stroke, while on antithrombotic therapy, it's because they actually weren't taking the antithrombotic therapy. And another reason that you can often go ahead.
Yeah, 100%.
Ashkan, you're the master of running 10 projects simultaneously. So I think an 11th project would be to have a registry of asundexian patients who are treated with thrombolysis. And if
Funny you say that. Okay.
And so,
yeah, for certain, it is. I agree. And this was something that companies like Bayer did after the DOACs came out, like the Xantus registry. It provides a wealth of information, and in particular for some of these more nuanced real-world scenarios that we may not have sufficient numbers within the trial, like thrombolysis, outcome of intracranial hemorrhages. And that's where a real-world registry can really help.
And I think Get With the Guidelines Stroke is going to collect this data because they'll add factor 11 inhibitors to the list of agents that people present with and collect the data on what happens to thrombolytics. And 75% of all U.S. patients are currently being entered into the registry. So we should very quickly get a lot of information.
Yeah, 100%. Very good. Another really good question. And one that I'm still uncertain about, but at least I have some opinions on, but I would like also be interested in the panel's opinion. Stroke patients, of course, require DVT prophylaxis. If someone is going to receive a factor 11 inhibitor on top of antiplatelet therapy as part of their admission, would they require DVT prophylaxis?
It's very good question. Very difficult to answer. It was easier for us when we were doing the trial because we treated this patient with DVT prophylaxis because we didn't know which kind of component was in how the patient was treated. We don't have the data, so probably I would go for DVT prophylaxis.
I think that would be probably the most by the book kind of conservative approach.
Yeah.
Because we just don't know.
Yeah.
Right? Now, there is a strong potential that we won't need it. The reason being is that, as we discussed in the epidemiology of factor 11 deficiency, patients who are factor 11 deficient have reduced rates of venous thromboembolism. There was a phase 2 dose-finding study of milvexian that showed that increasing doses of milvexian reduce VTE relative to enoxaparin. So there is some proof of concept that factor 11 inhibitors can reduce VTE. Personally, if someone was on antiplatelet therapy and a factor 11 inhibitor, I would start taking some risks, particularly if I was worried about bleeding complications or if they had GI bleeding or something else going on. I would feel comfortable probably in those settings avoiding the low molecular weight heparin. But I don't know what Jeff or Seaman think.
You'd probably be heavily influenced by the clinical deficit and the NIH score. If you have a patient whose NIH score is 1 or 2 at 24 to 48 hours and they're ambulatory, walking on the nursing units, you could probably make an argument to dispense with the DVT prophylaxis. But if you're treating somebody with a significant leg weakness and an NIH score of, say, 6 to 10, for example, I think you would definitely want to use DVT prophylaxis.
And that's a very nice approach to basically, individual-based.
You see, we have the guidelines, we have the evidence, but then we have the tailored approach to the patient, which is, I think, the best way to go.
Yeah. But really, based on kind of Valeria's initial response, is the one that's the most evidence-based. At present, we don't have any evidence that factor 11 inhibitor in this context can supplement the need for DVT prophylaxis. And in the trial, because it was placebo-controlled, most patients would have received DVT prophylaxis.
Yeah. So we have some data about safety.
Yes. Sure. Okay, the next question is, what level of factor 11 inhibition do you think is needed to achieve a clinical result? Well, it's hard to know what the bottom of that is. what we can say is that the dosing that was used in asundexian of 50 milligrams daily roughly results in a 92 to 94% reduction in factor 11 inhibition, depending on peak and trough, right? So that was the degree of inhibition that led to a clinical result in oceanic stroke. So that's what we can say at this point in time. Very good. I think we've run out of time, but thanks so much. It was really great. I really appreciate the engagement from the audience. Excellent questions, thought-provoking questions that certainly got a bunch of us on our toes, kept us on our toes and in our responses. Really, I couldn't think of a better group of panelists to be up here with me and trying to answer some of these difficult questions. Really the best and brightest of our community, so thank you very much.
This has been an activity published by Peer Voice.